might be no anterograde flow, but flow into the very hypoplastic ascending aorta and transverse arch is all going to be retrograde. Yeah, so this is that typical picture, and I will show some examples. So again, this is kind of our checklist that we can then go ahead and use as we go forward and review some of these cases here. So I have a few cases. So the first one is what I call single umbilical artery PSYCH-OUT. So this is a referral at 30 weeks gestational age. Mom was a 42-year-old G7P1, 5 prior terminations of pregnancy, and the patient was referred for single umbilical artery. The mom and fetus pair were otherwise well, and mother was somewhat anxious. And so we'll kind of look at all these structures that we've been talking about here. So this is our 4-chamber view, posterior, anterior. We have, I'm going to say this is left ventricle, right ventricle here. And there certainly doesn't look like there's any prominent size discrepancy. In terms of the foramen ovale, it looks right to left. Function looks normal. In the short axis view, again, this looks pretty normal. Here's our left ventricle, our right ventricle. There's a little bit of that discrepancy that we had talked about previously, but nothing that really stands out as being tremendously abnormal. In our 3-vessel trachea view, so anterior, posterior, so this is pulmonary trunk to ductus. This is aortic arch here. And again, if you look at the isthmus and the ductus, they're pretty much about the same size, maybe just a little bit small in terms of the aortic arch. And then here, again, same structures but with color Doppler, pulmonary trunk to ductus and transverse aortic arch. And here is an example of what I would call continuous anterograde diastolic flow, what we sometimes refer to as hang-up or drag. It's just a little bit abnormal flow there, but anterograde, so similar to that example that I showed you in those 4 3-vessel trachea view pictures. And then the same thing in a sagittal view, ascending aorta, transverse arch, descending aorta, and just a little bit of hang-up in the flow here, and maybe just a slightly small aortic arch, hard to say. Here it is without the color. And I think this highlights just how challenging imaging the aortic arch in a sagittal view can be. Often we are encounter head-on the spine, which casts all sorts of shadows over this region of interest here, which is the aortic isthmus. Again, part of the reason why this is so difficult. So in terms of our checklist here, really the only thing that's maybe a little bit concerning is the size of the isthmus and maybe a little bit of continuous anterograde flow. There's maybe a coarctation here, but likely not. Again, for counseling in this family, we would say this is likely normal. In terms of delivery planning, we would do this at a local hospital with a consultation prior to discharge. And this turned out to be a completely normal heart with no aortic arch obstruction. All right, so case 2, a misdiagnosis of hypoplastic left heart syndrome. And I want to emphasize here that this came to us very late, and we get this every few weeks or so. 36 weeks gestational age, assisted reproductive technology. Mom is 32 years old, 2 prior pregnancy losses, multiple prior normal obstetric ultrasounds, and referred for hypoplastic left heart and arrhythmia. Mom's anxious again. Family is anxious, I should say. So here, and again, we want to remember that this is at 36 weeks. So posterior, anterior, left ventricle, right ventricle. And there is a little bit more of that right-left size discrepancy that we had talked about earlier. Here in the sagittal view, I think that really comes out. Here's the left ventricle, and the right ventricle, by comparison, looks fairly dilated, so a little bit more impressive than the previous case. And we look at the aortic arch, and it looks as though the isthmus might be a little bit small. That's probably here in this region. And And here when we put color Doppler, this is a color compare image, 2D color compare, there's some antegrade flow, but you can actually see that there's some retrograde flow here as well. There's red coming back toward the transducer, which, as I mentioned before, is actually a pretty concerning sign. So what is going on here? Well, if we go back and look a little bit, it looks as though the foramen ovale is actually somewhat restrictive in this patient. So I do want to go back for just 1 second, if that's okay. I thought I had that included here. So if we look here, this is right atrium, left atrium, and we see this flap here. This is septum primum, or the flap valve of the foramen ovale, and it is basically bulging all the way to the wall of the left atrium, but there really isn't any meaningful flow going across it. So this is something that we see on occasion, which is premature restriction or closure of the foramen ovale in utero, which does happen when it does happen, typically late in gestation. Because the left ventricle is relying on that flow across the foramen ovale, the left ventricle becomes underfilled and there's less flow going antegrade across it, so we see retrograde flow in the aortic arch. Did I go too quickly? Yes, no, yes, maybe. This typically does not cause any significant postnatal issues. Again, there's decreased left-sided filling, small mitral valve and left ventricle appearance, and decreased antegrade aortic valve flow, retrograde arch flow, but this is not hypoplastic left heart. In fact, it's unlikely to be even coarctation. There can be transient pulmonary hypertension, but typically, again, this could be a delivery at a local hospital, and we would probably do an echo within 24 hours, mainly to rule out that there's any pulmonary hypertension.
So the primary diagnosis there is all of that, right?
That's what I would call it. I would call this a diagnosis of prenatal premature restriction or closure of the foramen ovale. There's one fascinating paper out of CHOP that shows that when you administer maternal oxygen, decrease the PVR, and increase the left-sided filling, that way you can actually reverse that retrograde flow in the aortic arch. All right. So case 3, this is a patient that came to us with an obstetrician-diagnosed hypoplastic left heart syndrome. This patient is at 22 weeks. There was a spontaneous pregnancy. There were 2 previous healthy pregnancies, and the father says that he has a history of a 2-valve. That's a direct quote. So it's always a little bit hard to sort out when the family says that they have something and you don't know exactly what it is, but 2-valve kind of raises the specter of maybe a bicuspid aortic valve or something like that. At least that's the way us fetal and pediatric cardiologists think. And anytime we hear about a bicuspid aortic valve, we think about the spectrum of left-sided obstructive lesions all the way from bicuspid valve to hypoplastic left heart syndrome. Mom as well, but I think illustrative of the challenge of prenatal diagnosis, the obstetrician diagnosis is HLHS, and they recommended termination of pregnancy, but the family did seek us out, and so that's how they came to us. So posterior, anterior, right ventricle, and left ventricle. And here you can see, unlike the previous case where we were at 36 weeks and there was a little bit of pronounced right-left discrepancy, here we are at 22 weeks and it's already quite discrepant. So here's the tricuspid valve, here's the mitral valve, this is the left ventricle, which does look kind of slender, but it probably reaches the apex. So although it's a little bit small, I don't know that I would leap to calling this hypoplastic left heart syndrome, again needing, staged palliation to Fontan or anything like that. Again, we'll use our complementary views. The right ventricle here looks markedly dilated. The left ventricle does look on the small side. Look at our aortic arch here. So this is our 3-vessel view, and we'll sweep through here. So this is pulmonary artery, the ductus arteriosus. Okay. Over here, this is aorta to transverse aortic arch. And you notice just how much smaller the aortic arch is compared to the ductus arteriosus. There are a couple of other cool, interesting findings here. Just orient you a little bit more. This dot is the trachea. This is the right side, so this is the right superior vena cava. But if you look closely on the other side, there is another dot here. So this is not a 3-vessel trachea view, this is a 4-vessel trachea view. And that extra dot turns out to be, my computer would cooperate. Oh, well, we'll get to that in a second. This is our our sagittal aortic arch view, ascending aorta, transverse arch. Remember how small it was in the 3-vessel view? So this is the kind of distal transverse arch isthmus, and all of these head vessels, it seems like they come off of a common trunk here, which is not uncommon in coarctation of the aorta. And when we put flow on here, hopefully these things will play, and they do play. When we put flow on, there is a couple of things. There is continuous anterograde diastolic flow, and there's actually a little bit of retrograde flow here as well. And then here, in power Doppler, which is sometimes a fun trick to use, you can really nicely see that there's continuous anterograde diastolic flow, and you can really get a sense for how small it is here. In comparison with this, any idea what this vessel is coming here, also connecting to the descending aorta? The ductus arteriosus. I didn't forget about that extra dot, I promise. So again, just to compare, this is our patient. Comparison with normal. I don't know why that media is unavailable. It was available just a second ago. There we go. So again, this is normal, and this is our patient here. Again, continuous antegrade diastolic flow, a little bit of reverse flow. And let's talk about that extra dot. Ductus, transverse arch in normal, abnormal, and here's that extra dot here. So that additional vascular structure turns out to be a left superior vena cava to coronary sinus. So you can see it here in the 3-vessel view. Here, although inadvertently I think I may have flagged the trachea here, but it has a similar appearance. And here, this is the dilated coronary sinus in the left atrium as well. So you can see this in multiple views. It can be a normal finding, but it can also go along with left-sided obstructive lesions.
So there's a double SVC in this case?
It's a double LSVC, yeah. So you have a right and a left. The left connects behind the heart to the coronary sinus. So in terms of our checklist, we have a number of red flags. The mitral to pericuspid, aortic to pulmonary, and aortic to ductal arch ratios are all abnormal. The absolute size of the shelf is abnormal. There's a posterior shelf, and there's a left superior vena cava to coronary sinus. So this diagnosis is most consistent with coarctation of the aorta. We counseled for likely coarctation repair, possibly an aortic arch augmentation, which is an important nuance because one requires circulatory arrest and bypass, the other doesn't. If the fetus is female, it's important to note the association with Turner syndrome. And then in terms of delivery planning, this would be an infant who we would recommend prostaglandin and transfer over to the CICU. Any questions there?
So the coarctation of the aorta resulted in the stimulation of hypoplastic left heart, basically. Yeah,
any time that there's inadequate anterograde flow to the transverse arch, you will often see that retrograde flow in the ductal arch. Yeah. All right, a few more, and I want to be cognizant of the time. We go till 8 o'clock, is that right?
More or less.
More or less, okay. I'll limit it to 9:15 then. So case 4 was limited views on obstetric ultrasound, which sometimes is a little bit concerning to us. So this was a 23 weeks gestation, parents not anxious at all. And here, unlike our other cases, there really is no identifiable left ventricle. This is a right ventricle. We identify it by the moderator band, septal attachments of the atrioventricular valve, single right ventricle, Here's what we had seen before in a couple of different settings. So this is ductus arteriosus, transverse arch, and here is red, which means by now you're all experts. This is retrograde flow in the transverse arch. So again, inadequate systemic output. Here it is in the sagittal view, ductal arch, and here's this flow coming backwards in the transverse arch. This is just by spectral Doppler to confirm what we were seeing. So in terms of delivery planning, and this actually is relevant to the patient that we had just discussed earlier with the pulmonary venous hypertension, what additional piece of information is critical for delivery planning? And one of the things that we look at is the pulmonary vein flow pattern. So a normal pattern looks like this with an SD and A wave. Oftentimes in hypoplastic left heart or other obstructive lesions, we see a little bit of reversal in systole, but we should see predominantly anterograde flow. And what we can use actually is the ratio of forward to reverse flow to determine whether there is going to be pulmonary venous or left atrial hypertension after delivery. This is the current patient, forward, and maybe just a little bit of reverse. Anything greater than 5 is considered at low risk for left atrial hypertension. Much more than that, we consider it to be, much lower than that. 3 to 5 is elevated risk, and less than 3 at high likelihood of needing some sort of intervention in the immediate postnatal period. So this is kind of what we have for this patient. Again, it looks pretty reassuring. We can safely deliver this patient, for example, at Washington Hospital Center and bring them over. And I think for this particular patient was actually delivered in Fredericksburg, started on prostaglandin, and brought up here completely, without incident. So hypoplastic left heart, mitral and aortic atresia. Counseling is for staged palliation. Again, prostaglandin and transfer to the CI. Now, this is a similar patient, but with an important difference. So this mom, actually, again, I don't mean to say mom, this family came to us at 34 weeks gestation. The family already had a diagnosis of hypoplastic left heart syndrome from a pediatric cardiologist in more rural Virginia, Grundy to be specific. They were well informed already about stage palliation. They knew about Norwood, Glenn, and Fontan. And their plan was actually to deliver at Buchanan Children's Hospital, followed by transfer to Inova in Fairfax for ongoing care. So that's here. And we're over here, just to give you a sense of the distances involved. And here we are. And, on the surface, this does not look tremendously different from the last case. Anterior, posterior, right ventricle, maybe a small hypoplastic left ventricle back here. But the important difference is here. So right atrium, left atrium, right ventricle. And you see here that there is an abnormally thick atrial septum. And this is going to turn out to be very important. Not only is the atrial septum thick, but these are the pulmonary veins here, 1 and 2. Obviously there are 4, but there are only 2 pictured here. And you can even see on this color Doppler image that there's significant reversal of flow. You see that red, blue there? So again, we're going to ask what additional piece of information is critical for delivery planning. And this is not a trick question. Again, the pulmonary vein spectral Doppler profile. So in this case, this is our forward flow, and this is our reverse flow, which in this case gave us a ratio of less than 3. So again, we look at our pulmonary vein patterns, normal here, normal for an unrestrictive hypoplast, and then abnormal. So this is what we're dealing with here. Again, just to kind of reemphasize that. And this becomes very important because for hypoplastic left heart syndrome, number 1, if you have left atrial and pulmonary venous hypertension in utero, you get changes in the pulmonary venules. We've known this for about 20 years. This is from an autopsy specimen, and it's probably responsible for some of those nutmeg lung findings that we sometimes see. So in utero, there's left atrial hypertension, pulmonary vascular changes, but postnatally, the oxygenated blood has to cross the atrial septum to get into the right ventricle to get into the pulmonary artery, to cross the ductus arteriosus, and then supply the body. So if the flow is completely hung up here, you can imagine after birth, rapid pulmonary edema, no pulmonary venous egress, and low cardiac output. This is the type of patient, again, very similar to the one that we discussed earlier, who may need an urgent or emergent cath and or septostomy or surgery and or a stage 1 Norwood in this particular case. And these are associated with a particularly high mortality. So in this case, delivery planning, we would really emphasize a controlled delivery and preparation for an urgent septostomy, ECMO, and or stage 1. Any questions about that, kiddo? Okay. All right. Last patient here. This is a referral for an echogenic focus in the left ventricle. This patient was currently at 18 weeks gestation. Mom was 18 years old, G1, otherwise healthy. The echogenic focus was noted on obstetric ultrasound, and mom was reassured that this was a common finding but sent to us for evaluation anyway. So this is a picture of the heart here. Let's see, posterior, anterior, right ventricle, left ventricle. The left atrium is quite dilated, and the left ventricle is actually not working normally here. And you can see, yes, there are echogenic foci, but that actually looks to be the actual myocardium itself, not the kind of apparatus of the mitral valve. And what is going on here is that there's actually, severe aortic stenosis, so much so that there is reverse flow in the transverse arch. There is mitral regurgitation, that's significant. And there's a dilated and dysfunctional left ventricle. There is diastolic dysfunction as well. That's the left atrial enlargement, abnormal mitral inflow, abnormal tissue Doppler there. And this is a case of fetal aortic stenosis and evolving hypoplastic left heart that one can consider fetal intervention, which looks something like this. So here's the needle going into the the dysfunctional left ventricle, and a wire and a balloon is going to be inflated across the ascending aorta to try and relieve aortic stenosis. An important feature of this is the endocardial fibroelastosis, so that echogenic focus was actually the scarring in the left ventricle. Outcomes are a little bit iffy here. Of all these patients who underwent this procedure, of the first 100, 38 have a 2-ventricle circulation instead of single ventricle, but a lot of them needed additional procedures on the mitral valve, aortic valve, sometimes valve replacements. Some underwent stage palliation initially. So in truth, that echogenic focus was the left ventricle. It wasn't an echogenic focus in the left ventricle. So again, a possible fetal cardiac intervention, but it's very important that these families understand that there is still significant need for additional procedures, surgeries, and potentially even stage palliation.
How many centers are there currently doing the aortic dilation approach?
Boston, far and away, has done the most, but I believe UCSF and Texas Children's and a few centers internationally are doing it as well, and there is an international registry, but by far the most robust experience comes from Boston. So that first 100 patients is from Boston Children's there. So I know we're a little bit pressed for time, but hopefully you all have a sense now of the challenge of diagnosing coarctation in utero. And hopefully you understand normal cardiac proportions and how abnormal cardiac proportions can be helpful. You understand the utility of the pulmonary vein spectral Doppler profile and HLHS. You understand the importance of looking at the foramen ovale, and a little bit about fetal cardiac intervention for those rare cases of aortic stenosis and evolving hypoplastic left heart. And this is our fetal checklist, which you're able to take a look at anytime if you'd like. So that's it. Thank you. Sorry to run over.
No, thank you very much, Dave. Can I just ask you one So this whole issue with retrograde flow in the aorta, when there is decreased oxygen delivery to the brain, there's vasodilation, and that would, of course, make retrograde flow easier, right? Do you ever factor in the relationship into your anatomic diagnosis, the relationship between vasodilation in the brain versus obstructive flow? So that's an additional, so if hypoxemia gets into the brain, for example, because of a downstream. Does that ever come into play that you have to factor in?
It certainly comes into play, and we know that there's a kind of brain-sparing effect. We know that that retrograde flow does not provide normal oxygen content, probably just the abnormal flow profile, the kind of decreased pulsatility index, and we have known for a while that a term fetus with hypoplastic left heart syndrome does not necessarily have a term brain. And I think that definitely becomes important in terms of considering timing of delivery and counseling families, but I think that would be the way that it kind of comes into play.
But not so much, it doesn't really affect your anatomic diagnosis, it's more in terms of management and
I think so, yeah. Yep.
Any other questions?
David, a question regarding delivery recommendations. Have you ever had a family at the birth instead of, because
instead of a hospital?
Here we say delivery at the local with.
Yeah, I think that gets into the delivery planning and the level of care system that we use here. So for a lot of lesions, for example, ventricular septal defect or even atrioventricular canal, if the baby is otherwise well, it's probably reasonable to let that happen because the likelihood of any sort of perinatal compromise due to the heart is very low. But if you get into a prostaglandin-dependent lesion, then you really, I mean, there's no alternative. You definitely have to jump on that. So.
I have never thought about, this babies even with when we one opening also in Texas, meaning a deep and that to deal with.
Interesting. Yeah.
Any other questions on the outside?
All right.
Well, David, thank you very much.
Thanks. No, my pleasure.
I really appreciate it. Thanks.
Thanks. No, thank you for having me. Anytime.
Yeah, no, that was
Welcome back.
for me right at the right
It's
level.
summer already?
Yeah.
Oh my goodness.
Very quick.
Do you want me to save anything here, or are you all good?
I'm getting used to that meeting.